what do you think are the biggest barriers to the prescribing SGLT2s sort of at the proper rate that we should be doing? And is it sort of clinical inertia, or I've heard a lot of people cite costs. What do you think are the biggest barriers to this?
Yeah, thank you, Patrick. I think, as with many things in medicine, it's a convergence of factors. And I think that the two that you had mentioned of clinical inertia and cost are probably chief among them. I'm hopeful that the SGLT2 inhibitors are actually fairly unique compared to other novel therapies in that we've rarely seen a therapy being shown to be effective in so many different therapeutic domains in such a short duration of time. So I'm hoping that creates enough momentum that it actually reaches patients, reaches clinicians, and spurs change and helps overcome that therapeutic inertia. Costs are an issue with the adoption of any novel branded therapy. I think there has been improvement and progress in terms of coverage. Has been fairly progressive in terms of covering the SGLT2 inhibitors, and I think that I'm hopeful that as health systems also attempt to adopt these therapies on a broader scale, there may be greater cost sharing and opportunities to actually reduce out of pocket costs borne by patients.
Outside of patient adherence, what are barriers that are sort of preventing the optimal prescribing of GLP-1s?
That's great. So all of the currently cardioprotective GLP-1 receptor agonists, those therapies that have definitively been shown to reduce major adverse cardiovascular events, are all injectable therapies. And in general, for type 2 diabetes, most patients are accepting of injectable therapies because a large portion of patients are already on insulin. And adding another injectable is generally reasonable. However, there are patients that may have needle phobia or other maybe otherwise averse to initiating an injectable therapy. And I think that adding oral options has really been a clear interest amongst patients and clinicians. Um, as of late last year, there is a new oral GLP-1 receptor agonist. It was shown to be safe with respect to cardiovascular risk, and it's currently underway in terms of cardiovascular risk reduction testing in a large-scale randomized clinical trial called SOUL. And so I think we'll learn more about whether we can actually use more easily adopted oral versions of the GLP-1 receptor agonist that may improve the overall uptake